Maybe just as people are trickling in, are there any questions that people want answered on this topic? Because I feel like for some people, this won't be the first time they've heard about venous congestion, and uh, I'm happy to tailor kind of discussion to what people want to learn about. So just maybe inviting everyone to kind of contribute now if there's certain things that they want us to touch on, or perhaps put it in the chat there, and I have the chat window open so I can answer chat questions live as we're talking here. Hopefully we can keep it as interactive as possible. Maybe just even a poll if people want to just respond back with like an emoji, a smiley face, if anyone has um, heard of venous congestion before, just to get a sense of what people's familiarity with the topic is. Hell yeah. I like it. Yeah, so the role of kind of ventilated, yeah, we'll talk about confounders for venous congestion and how to conceptualize them for sure. Tricuspid regurg is another one that comes up a lot, so we'll make sure to talk about that. Belomo kidney. I have no idea what that is.
Yeah, I have not heard of that before.
Sounds like a delicacy from Italy or something. You think we have quorum here to start?
Yeah, let's do it. So thanks everyone for joining us today. On behalf of the Critical Care Program and Scarborough Health Network, I'd like to welcome Dr. John Basmagi and Dr. Ross Prager to Medicine Grand Rounds. We're absolutely thrilled to have these two world-leading POCUS experts present to us today on venous congestion physiology. Dr. John Basmagi is an intensivist and clinician scientist from the University of Western Ontario. His research program is focused on studying the impact of point-of-care ultrasound in research and the management of shock. And Dr. Ross Prager, who's an intensivist from the University of Western Ontario as well, with a special interest in POCUS, venous congestion, and knowledge translation. So a big warm welcome to you both. Thanks so much for being here today.
Thanks a
Thanks
lot,
again for
Peter,
having
for that
us.
introduction. Yeah, we're very excited for this.
Yeah, we're going to do a bit of a kind of tag team here where I'll start off a little bit on the evidence and some of the kind of physiology behind it. And then John's really going to take us into the future directions, highlighting some of the research that we have going on relevant to this topic. So we're going to talk about a few things here. I guess I have no conflicts here. The only kind of relevant thing is I use generative AI to do a lot of things, so it's probably stolen from other artists on the internet. So I apologize to those people whose livelihoods I've ruined. So the first thing that I want to talk about is the concept of organ perfusion pressure or renal perfusion pressure. We know about this concept intuitively from intracranial pressure that we've all learned about. There's the map or the pressure going in, and then there's some sort of resistive pressure, like your ICP. And we in the ICU really fight to maintain cerebral perfusion pressure for patients with elevated ICP. And I think we know that every organ has a perfusion pressure, but we might not think about it that explicitly. In the ICU, we maintain MAP at all costs. We wouldn't let a patient sit there with a MAP of 50. We them on vasopressors, give them fluids to try to restore that to a better pressure. The other side of the equation is the central venous pressure. And admittedly, it's something that I don't think we're quite as aware of because really your perfusion pressure factors in what's going in, but also what's going out. And you're saying, well, okay, a map of 70, a venous pressure of 10, you have a gradient of 60. So what if your venous pressure goes up from 10 to 15? Unfortunately, that's not really how it works. So there's an arterial venous pressure gradient. And when the blood leaves the heart, it's at the highest pressure. And then when it returns back to the heart, it's at the lowest pressure. That's why blood flows forward in the body. The actual artery supplying the nephron and the actual functional units of the kidney is not your aortic pressure at like 85. It's a small arterial with a pressure of, say, 45. And so when we have a normal CVP, say a 5, and that goes up to 20, we've actually reduced our perfusion pressure across our kidney by a significant amount. And that's why our kidney may be particularly sensitive to changes in venous pressure. And this has been studied with central venous pressure. So in septic shock patients here, we can see that higher CVPs are associated with acute kidney injury. And that's independent of some other factors that you'd think of. When we look at a large population of American critically ill patients, we see that again, there's this consistent association between central venous pressure and acute kidney injury, particularly for patients with this low systolic blood pressure. And this might kind of make us think more of perhaps like septic shock patients or really kind of vasodilated patients. And so you might say, okay, well, great. CVP is associated with acute kidney injury. Why are we talking about kind of venous congestion? And why are we going to talk about Doppler ultrasound here? But there's a problem with this. And the problem is that at population level, yes, high venous pressures are associated with AKI. For an individual patient in front of you, they really have poor sensitivity and poor specificity. So this was a study comparing kind of VEXIS to CVP and found that CVP of above 12 has an 83% sensitivity, but only a 33% specificity. But I think this makes sense for a lot of us. And there's a couple of reasons why CVP fails at predicting acute kidney injury. So the first, CVP is a centrally measured pressure at the right atrium. That isn't necessarily what the kidney is experiencing, which is in a different body compartment entirely. There's other pressures at play here, perhaps intra-abdominal pressure. Second thing is there's also a conduit, the blood vessel that transmits blood from the kidney or returns blood from the kidney back into the right atrium. A different tone on that can affect how pressures are transmitted retrograde to the organs. And then I think the thing that we all know intuitively is that some patients actually require elevated CVP to maintain forward flow. Think about a patient with chronic RV dysfunction, chronic kind of diastolic dysfunction, or pulmonary hypertension. Those patients live with a CVP of 16. For that patient, they actually might need an elevated CVP to maintain forward flow. And if we try to lower it, that could actually be harmful, particularly when a CVP of 16 for some patients is harmful and other patients is not. And so this has really led us to want to search for alternate metrics to look for venous congestion and has really brought in the idea of Doppler ultrasound as a point of care tool. And so a lot of this literature came out of the cardiac surgical population, a lot of it by some of the intensivists and cardiac anesthetists in Montreal, like André Deneau and his colleagues, including William Beaubien-Souligny. They found that portal vein pulsatility, that's PF, of above pulsatility above 50% was associated with acute kidney injury post-cardiac surgery, which is kind of interesting. And so a normal portal vein has a totally smooth, continuous flow of blood. And as we start seeing higher pressures and higher retrograde pressures transmitted from the right atrium, it starts becoming pulsatile. and talk about that. When they looked at it, or when these authors looked at it prospectively, we found that portal vein pulsatility, again, that 50% threshold, was associated with an increased hazard of acute kidney injury following cardiac surgery. Now, also the renal vein, when they're looking at it. So if we look at pattern one, which is just a normal pattern, there's a hazard for acute kidney injury. Some patients will still develop AKI. But when we start getting moderate or severe congestion patterns, so biphasic or monophasic that we'll talk about, there's an increased hazard for acute kidney injury. And this really led some of these kind of early investigators to think, can we combine this into a multiple organ assessment of venous congestion? Because each Doppler, portal vein, renal vein, hepatic vein, and inferior vena cava has strengths and limitations. Maybe if we combine them all together, we'll get better predictive ability for acute kidney injury, particularly following cardiac surgery here. And so when we first look at the hepatic vein, I'm going to go through what the waveforms are. A normal pattern has a little bit of retrograde flow during atrial systole. So that's backwards flow above the baseline here. Most of the forward flow is in systole, and then you have a little bit of forward flow during diastole. That's normal. What happens as you get worsening congestion is you start seeing blunting of how much blood flow is going forward during systole here. Most of it now is diastolic. And eventually, with severe congestion, you actually have a reversal of your systolic flow, and you only have forward flow during diastole. And just to conceptualize this means that blood is going backwards and forwards in the vein. Our body really likes it when blood is moving forward, not backwards. And so you can understand how this could actually reflect severe congestion. At the portal vein level, portal vein is normally this kind of smooth, fairly continuous, maybe mildly pulsatile, but fairly continuous Doppler pattern. As we start getting mild congestion, we start seeing a bit more pulsatility, and eventually we see severe pulsatility, well over 50%. And this can actually start going backwards, where it starts, again, reversing the blood flow in the portal vein. And that's really impressive. If you think about how that has to happen, you have your right atrium, the blood flow is going backwards into the IVC, into the hepatic vein, through the hepatic sinusoids, and then reversing the blood flow in the portal vein on the other side of the liver. That's a marker of severe congestion. And then the last pattern that they looked at in the VEXUS score here is the intrarenal venous Doppler. And ignore everything above the baseline. This is the arterial waveform. And when you Doppler the kidney, you often get an arterial waveform because the small interlobular veins and the interlobular artery run together. They're kind of intertwined. So when you Doppler, you get them both. So under the baseline here, though, you can see that there's a small, smooth venous pattern. It's continuous. That's normal. As you start getting more congestion, you start seeing a biphasic pattern. Look, there's now periods of interruption. That period of interruption where there's no blood flow draining the kidney is kind of analogous to a compartment syndrome of the leg, for example. If you have a compartment syndrome of the calf, you get arterial blood in, but the first thing to go as the pressure goes up is you lose the venous drainage, and it creates this positive feedback cycle where that compartment gets tighter and tighter and tighter. Your kidney is actually encapsulated in Gerota's fascia. As you start losing venous drainage, you start getting interstitial edema of your kidney, which causes dysfunction. And then finally, as congestion gets very severe, you only drain your kidney during a brief period in diastole. You completely lose systolic drainage of your kidney, which is very abnormal. So the question is, what did it actually show? So when you compare VEXUS to CVP, and these are called leaf plots, essentially they show if a test was positive. So if the VEXUS was positive, how does that increase your post-test probability for acute kidney injury? And there was a strong association between worsening congestion and acute kidney injury. That was beyond central venous pressure, because that's one of the big criticisms of VEXUS is, well, it's just measuring central venous pressure. Why do we care? Well, it seems to have an additive effect beyond measuring a central pressure. But the question is why? But we'll get to that question in a second. First, some of the evidence in the ICU here. So for kind of general ICU patients, there's a odds ratio of 4 for worsening hepatic congestion and MAKE 30, which is a composite of renal replacement therapy, AKI, and death. Portal vein pulsatility also had an association, but if you look at it as a continuous variable, it's maybe a bit more mild of an association. There's multi-center data from patients with acute kidney injury that having worsening congestion scores is actually associated with death, even if you have acute kidney injury already. And this was some recent work. So what actually causes venous congestion? And again, I'm just going to go through the waveforms one more time just so we're all familiar. So hepatic vein, normally there should be mainly forward flow. Forward flow is below the baseline. We start losing some of that systolic flow. And then eventually that systolic wave goes reversed. Portal vein, it should just be smooth. We start getting a little bit of kind of pulsatility here. And even with severe, you can get this reversal again, or just severe pulsatility. The renal vein starts continuous, but eventually you get this biphasic drainage, and then eventually you get monophasic drainage. So what actually causes venous congestion? And it's really kind of attractive just to think of it, and thanks to Abelish Cortala for this figure from NephroPOCUS. It's really attractive to think of it like it's just a marker of volume overload. You have elevated right atrial pressure, it gets transmitted retrograde, say, into the IAJ and the IVC, and then that just goes retrograde into the kidney. So really, this is just a fancy way of measuring right atrial pressure non-invasively instead of using a central line. Unfortunately, that's not totally the case. So the reason why is venous congestion is really multifactorial. So the first thing is there's a lot of factors in the heart that affect venous congestion. So the first is RV function, systolic and diastolic, pulmonary pressures or pulmonary hypertension, the presence of pericardial diseases, including pericardial effusions, and tricuspid regurgitation. I'm going to come back to that because I get a lot of questions about that. The second is somebody's ventilation status. Are they on positive pressure ventilation? What's their PEEP? And are there pleural effusions? There's actually evidence that patients with higher PEEP have worsening renal congestion and actually have more abnormal intrarenal Dopplers. Similarly, patients on positive pressure seem to have worsening congestion of the kidneys. And we actually know this intuitively from other evidence in ICU that mechanical ventilation is actually an independent predictor of acute kidney injury. There hasn't really been a mechanism proposed for that, but perhaps this is one of them. IV fluid. So if you give somebody 15 liters of fluid, uh, that can also cause worsening congestion. But if you notice, that's only one of the like 9 things we've listed that actually causes venous congestion because again, IV fluids and volume overload is not the same as venous congestion. And then things like intra-abdominal pressure, renal edema, IVC stenoses. We've seen cases of post-transplant IVC stenosis with kind of thrombus with severe renal congestion that when they went in and got rid of that thrombus, immediately caused normal renal perfusion. So with all this said, and please feel free to put any questions in the chat here, why do we care about this? Like we can measure CVP already. There's all these factors. And so when it really comes down to it, the reason why I really like venous congestion, why I think it's useful, is the kidney does not care why it's congested. The kidney, whether it's tricuspid regurg or because of increased PEEP or because of pleural effusion, when you show that somebody has severe renal congestion, that's the truth that that kidney is experiencing. It doesn't mean that you need to diurese them. It doesn't mean that you can fix their congestion, but that is the physiologic state of the kidney. And that's the reason why they're having their, or that may be the reason why they're having their organ dysfunction. And so it kind of takes away some of the noise. It doesn't really, the actual treatment of your renal congestion depends on the cause, but the actual state of congestion is independent of the cause, if that makes sense. So somebody with severe TR and severe renal congestion because of their tricuspid regurg is probably experiencing organ edema at their kidney because of it. We just might not be able to intervene on it unless you're doing tricuspid clips or something like that. So the first use of venous congestion that in my practice and our practice and our research is differentiating between congestive and hypovolemic AKI. A great example, a patient gets brought in with cardiorenal syndrome or volume overload in the ICU. You're diuresing them, and like 3 days in or 5 days in, the creatinine starts going up. We see this on the medicine ward all the time. And somebody says, could they be intravascularly dry? Well, if they still have severe congestion in their organs, it actually might mean that your diuretics have been ineffective and we need to actually escalate doses. And this has been studied in acute decompensated heart failure, and there's some RCTs ongoing actually looking at VEXAS-guided decongestion in that population. Again, kind of the cardiorenal syndrome decongestion population. Could it be a stop point for IV fluid resuscitation? So if you started with a patient, say with septic shock that you were giving fluids to, and they were not congested, but then they start developing early signs of venous congestion, is that potentially a marker to switch over onto vasopressors? And that's something that Dr. Basmaji will talk about a bit more and is kind of part of our research. Is it a start point for de-resuscitation? So you have a patient in the ICU who has received resuscitation and emerged appropriately for their hypotension and they're on vasopressors, But now they come in and you notice that they aren't peeing much. You look and you see severe renal congestion. They have acute kidney injury. Is that a point that we should actually start decongestive therapy or deresuscitation? Maybe that's Lasix. Maybe that's RV support with inotropes or pulmonary vasodilators. Again, congestion is not the same as overload, so perhaps this patient needs other therapy and this isn't actually a volume issue. Maybe they need their pericardial effusion drained or their pleural effusions drained. And then this is something that we've noticed a fair bit, and perhaps more in the context of femoral vein Doppler, which we haven't talked about too much. But is it a marker of acute occult RV pathology that requires investigation and treatment? And so when you see unexpected severe congestion, maybe the patient didn't really get much fluids. It may just be a downstream consequence of RV failure. And when we think about how RV failure causes organ dysfunction, I at least would always think that, well, of course, the RV fails, you have bad cardiac output. When you have bad cardiac output, your organs fail. But going back to that idea of perfusion pressure, as your RV fails, the venous pressure also increases. And that venous pressure and that venous congestion can reduce the perfusion gradient even with a normal map, which is why sometimes we see patients with normal maps and cardiogenic shock with normal cardiac outputs with severe organ dysfunction. And this may also be a prognostic indicator, particularly for patients with heart failure, where patients with refractory severe venous congestion have worse survival kind of longer term compared with other patients. So we actually looked at this in London, and I'll present some of the results of our pilot study here. So we looked at 75 patients with septic shock, and we performed venous congestion kind of markers like Vexus on day 1 and day 3. And the first thing is about 20% of patients, and this was on ICU admission, had venous congestion, which was actually higher than what we were thinking. These are patients that we expect to be kind of vasodilated, not kind of congested. There was a dynamic component to it as well, where some patients that started congested became not congested, and some patients that started not congested became congested. And we looked at the fluid balance between these groups that transferred over. And again, this wasn't really powered for this, so we have to interpret this with a little bit of caution. But patients that were congested and went to not congested had a more negative fluid balance. Patients that went from not congested to congested had a higher fluid balance, with kind of a p-value that's pretty borderline. So a high degree of skepticism here and healthy skepticism here. But venous congestion was associated with the need for dialysis, particularly kind of early on in the course here, with a hazard ratio of 3.35, and the p-value again 0.06. But this is why we're going to study this in a larger study, and that really led us to a study called Andromeda Vexus. And so this is actually an observational sub-study of a randomized control trial called Andromeda Shock 2. You might be familiar with Andromeda Shock 1, which was the randomized control trial of lactate compared with cap refill guided resuscitation in septic shock. Andromeda Shock 2 is an international RCT looking at phenotyped resuscitation using cap refill time, a bunch of clinical parameters like pulse pressure, diastolic pressure, fluid responsiveness testing, trying to optimize organ perfusion. And we're performing an observational sub-study where we're looking at Vexus early on in the course to see whether or not that's associated with adverse outcomes. And we have a lot of kind of learnings from that we're happy to share. We're about almost 200 patients into recruitment around the world. The study's primarily out of South America, but we have collaborators kind of throughout Europe, North America, Canada, and with kind of Peter Reardon here being a site here in Canada that we're kind of discussing getting onboarded. So a couple take homes here, and then we'll pause for some questions before I hand it over to John. So the first is that there's evidence across multiple populations now that venous congestion is associated with organ injury, particularly AKI, also potentially death and dialysis, fairly patient important outcomes. If you give somebody a ton of IV fluids that they don't need, that may contribute to venous congestion. With one caveat, it probably contributes to venous congestion if they have other risk factors for right-sided pathology, at least in my mind. So for example, right now, if somebody hooked me up to an IV and gave me 10 liters of IV fluid, I probably wouldn't have severe venous congestion. I would be able to just quickly mobilize that fluid and pee it out. But take somebody with some RV diastolic dysfunction, pulmonary hypertension, tricuspid regurg, that patient can't accommodate that fluid, so may experience adverse effects from venous congestion. Venous congestion is not the same as volume overload. It's that interplay between the cardiothoracic kind of physiology, PEEP, pleural effusions, RV physiology, tricuspid regurg, with intra-abdominal pressure. congestion guided therapy is feasible for centers around the world, and we've demonstrated this. I know VEXUS seems like a super complicated score that nobody could learn. We've actually taught centers that have no experience doing VEXUS via webinars, and they're recruiting patients into our study with excellent data quality. There are it can be hard, and particularly the renal Doppler. It takes a bit of time and experience to get comfortable doing that. But we've demonstrated that this certainly is feasible. So if anyone's interested in learning more, like reach out to us. We're more than happy to come teach a VEXUS workshop for at any of your hospitals, for any of your departments. This is just something that we hope we can spread and has value for patients. So with that, why don't we do a few questions here and then, yeah, and then I'll hand it over to John there.
Hey, thanks so much, Dr. Prager. That was amazing. Anybody, if you have questions, please feel free to drop them in the chat anytime, and the presenters will either address live or at the end. I did have one question for you. Is there any role for CVP use in combination with VEXUS assessment? Like, let's say they correlate initially, you have a very high CVP, and the VEXUS shows congestion, just to monitor for ongoing response to therapy, where you don't necessarily have to bring the ultrasound in at the bedside and reassess them on an ongoing basis. Any role for CVP in that context?
Yeah, it's a good thought. Like, so you have a patient with a CVP of 18, they're severely congested, and then you're like, okay, the two align. So now if I bring the CVP down to 14, do we know if that correlates with improvement in the organ congestion? So I would say that in short, there is evidence of an association between right atrial pressure and VEXUS. That has been established. So the short answer is yes, but I worry because patient's renal congestion could have factors that are contributing beyond just the CVP, intra-abdominal pressure, ascites, PEEP, other things that may influence the CVP and the renal congestion differentially. So I don't think I would personally rely on that. Um, yeah, there probably is a correlation there, but I'm not sure it would be perfect. I see
Yeah, it
another
may be
question here.
yeah,
Oh, go
maybe a
ahead.
loose correlation, Peter, because the truth is like there's so many factors that converge on a venous congestion itself. Therefore, just looking at CVP may correlate, and so that may actually change within the patient and also between days and between patients too. So I'd be worried about that association.
Yeah. And I see a question here about renal vein flow in end-stage renal disease. So, really good question. So that is an area of ongoing research. So Eduardo Arguez is a nephrologist and VEXUS expert in Mexico City. He studied a fair bit of VEXUS in end-stage renal disease population. I think he looks a bit more at the portal vein, but all kind of the same concept. And I think there may be a role in VEXUS to help control somebody's like dry weight. And so he has the luxury that all patients in his hospital um, are only patients affiliated with his hospital because it's like a specialty hospital. So he actually has these patients, they're like dry VEXUS scores as an outpatient that he follows. And when they present acutely, can then see whether or not their congestion is worse than baseline, then titrate therapy and decongestion and inodilators in response to that, which is pretty cool. So it's certainly an area of ongoing research, and I think there is value there. Potentially similar to the B lines that a lot of people have talked about, looking at somebody's like dry lung ultrasound profile. I think there could be a dry kind of renal congestion profile. So definitely. And maybe I'll just answer one question that we often get, and just prophylactically, because I think this is such an important point. So, what about tricuspid regurg, and what about like kind of ventilation? So tricuspid regurg causes hepatic systolic reversal. That is one of the markers of severe congestion. So people say, well, is VEXUS valid in patients with tricuspid regurg then? Or is that just a marker of the TR itself? And how I would conceptualize this is there's VEXUS and then there's venous congestion. VEXUS is a score trying to quantify venous congestion that has limitations. Venous congestion is physiology, where high venous pressures are transmitted retrograde and organs experience adverse outcome or adverse effects due to this physiology. Tricuspid regurg may confound the VEXA score itself a tiny bit by overweighting the hepatic vein, because sometimes these patients with TR have very abnormal hepatic veins, but their renal veins aren't then congested. But if you have a patient with renal congestion and severely abnormal renal Doppler and tricuspid regurg, the tricuspid regurg might be contributing to that, but it doesn't mean that it's irrelevant. The kidney is still congested. The kidney's like, "Oh my god, like, I can only drain during a tiny bit of diastole," regardless of the etiology. The etiology informs treatment, not necessarily the prognostic association between congestion and AKI. If that makes sense. But that's something that we often get asked, and, one of the things from our study that, John will talk about is we've seen some pretty crazy patterns of congestion that don't make sense. Like, you have a patient with a totally collapsed IVC, totally normal hepatic vein, totally normal portal vein, with severe renal congestion and AKI. And, like, how does that fit with this current schema of pressure going from the right atrium into the IVC into the kidney? There's certainly areas that we're still trying to figure out, and that's the purpose of doing the multi-center study. So thanks again, everyone, and feel free to reach out on Twitter or kind of wherever. Email me, get my email from Peter if you have more questions, and or if we can help kind of facilitate learning around Vexus for your departments or divisions. So thank you guys.
Thanks, Ross. I'm just going to share my screen now. So we've heard a lot about Vexus, and so I wanted to take a step back and kind of think about what problems can Vexus solve, and what role does it have when it comes to our ICUs. We've talked a lot about kind of the multifactorial, contributors to venous congestion, but one of the factors that gets a lot of attention is actually fluid administration, mainly because it's a very modifiable, iatrogenic, potentially source of injury to patients. And the truth is, many existing methods of identifying organ injury due to excess fluids are actually insufficient for us. So if you look at the people often use the chest X-ray, physical examination as deresuscitation endpoints, and those are insufficient because you only identify fluid overload after it's accumulated. We've talked about CVP a lot, and it still remains an unreliable surrogate. So at the end of the day, it still measures right atrial pressure, but it doesn't reflect exactly what's happening to the organs and what exactly the organs are seeing. Vexus is a way to cut through all that and give us a physiological window into what the organs are seeing from a venous congestion perspective. Well, a lot of people have also said, well, we have tools that determine fluid responsiveness, and that may be true, but the truth is a lot of the fluid responsiveness measures kind of tell the arterial side of the story, and they don't necessarily tell the venous side. And a lot of times people will say, well, if fluid responsiveness tests do not necessarily show that a patient's going to respond to fluids, I may still kind of give a fluid challenge to see. And it's important to remember that the absence of benefit does not mean the absence of harm. But more importantly, a lot of fluid responsiveness guided resuscitation have not actually been shown to improve outcomes in patients with septic shock. Some good literature in surgery, but not necessarily in a septic shock cohort. There's also existing knowledge gaps within Vexus, and it's important for us to acknowledge this before we move on to the next phase and push the frontiers and boundaries of knowledge. Venous congestion measured using Vexus has largely been studied in a cardiac, surgical, and a general ICU population. And what we're interested in is looking at septic shock. There's actually potentially very important differences, right? In septic shock, patients are very susceptible to ischemic injury from a lack of volume due to kind of the septic shock physiology. But there's also the concept of endothelial dysfunction and capillary leak, and therefore the thresholds of venous congestion and where it becomes important or not important for patients' septic shock actually begin to matter. Most of the existing literature on Vexus right now has actually reported surrogate outcomes. We've seen a lot of data on AKI, but the truth is AKI is pretty transient, and it's not necessarily important to patients if it's detected on blood work. What about things that are really important to patients in healthcare systems, things like renal replacement therapy and death? And then the last thing is, what is the relationship between cardiac dysfunction and venous congestion? One of the things that we found in our pilot observational study was that there was a much higher proportion of patients with RV and LV dysfunction on echo in the congested group than there was in the non-congested group. And it was interesting also that we found that the cumulative fluid balance of patients in the congested group was actually lower than patients in the not congested group. And we have a lot of hypotheses, but one of them could be, does the threshold for venous congestion change based on your cardiac dysfunction or your level of cardiac function? And so the goal of our research program is to determine whether or not venous congestion measured using VEXAS is independently associated with very important outcomes for patients and healthcare systems, namely the need for renal replacement therapy and death. The idea behind that is if we assume that venous congestion is a modifiable factor, then can preventing or treating venous congestion reduce the risk of renal replacement therapy or death? And that future research question is something that we could study in the context of an interventional randomized controlled trial. So with regards to our VEXAS program of research, we've started off by completing a pilot observational study that Ross and I have shared some of the data with. And the aim of this was not actually to look at clinical outcomes, but to more so determine the feasibility and reliability of performing high quality VEXAS scans and building that research infrastructure. The clinical outcomes that we've talked about are more exploratory and hypothesis generating. The next phase of our research program is actually looking at doing a definitive observational study to determine whether VEXAS is independently associated with renal replacement therapy or death. And that's where we are right now. And this is the study that I would like to invite you guys to participate in. The idea behind that is if we can establish that association definitively, and if we assume that venous congestion is a modifiable risk factor, then we can test it out in a randomized controlled trial in phase 3. And so our current Andromeda VEXAS definitive observational study enrolls patients who meet sepsis 3 criteria for septic shock. Within about 16 hours or so of them meeting the diagnosis, we perform the VEXAS scan, and then at 28 days we look at outcome data, and then we're looking to correlate the association between venous congestion measured using VEXAS and clinical outcomes. So why is this something that's important? Well, current resuscitation strategies could be contributing to iatric organ injury, whether it's too much PEEP, excess fluids, not treating sepsis-induced cardiomyopathy. And using VEXAS, we could actually tailor management based on individual patient needs and prevent iatrogenic injury that may improve patient outcomes. VEXAS, we believe, has the potential to disrupt the conventional paradigms of management. And what does VEXAS-guided management look like? And so this is the phase 3 of our pilot RCT. This is actually something we just recently got approved for funding to do a local pilot study as we prepare and as we kind of finish the phase 2. But the idea behind that is patients who kind of may get randomized to the VEXAS fluid management arm will have a VEXAS performed immediately. And one of the ways that this can be incorporated in clinical practice is based on the VEXAS score, we can kind of tailor therapy. So if you've got, VEXAS of 0, you just monitor. If you have VEXAS of 1, then you may kind of target a slightly negative fluid balance and hold back resuscitation. But when you've got VEXAS 2 or 3, which is moderate to severe congestion, not only would you be looking at fluid balance, but you'd look to optimize cardiac function, optimize PEEP, really address the multifactorial nature of venous congestion, and then repeat the VEXAS scan. Our dream and our vision is that resuscitation and deresuscitation are no longer two different phases, is that if we can imagine a way to resuscitate and treat patients in a very elegant way where there's not two phases where we pivot because we've gone too far, where we do just enough and stay in the middle, and it's just one continuous elegant phase.
Ron, can I just hop in for a comment here really quickly?
Yeah.
One thing that I think is kind of ICU and site specific is the idea of deresuscitation while on like high doses of vasopressors. And so I'm sure many clinicians and intensivists on the call here think like, oh, like patients on like 30 of levo or like 0.5 per kilo of levo, like we can't start diuresing them. We can't start kind of renal replacement therapy. But one of the things is if somebody has severe congestion and RV dysfunction, you can take off as much fluid as you want essentially on renal replacement therapy. And their hemodynamics and organ dysfunction don't get worse. If anything, they get better. And that's something that kind of identifying these patients that are congested gives you actually a bit of a window of safety. And there's some emerging evidence in a dialysis kind of setting that if you have a patient with severe congestion, you can remove more fluid before you cause intradialytic hypotension than patients who are not congested. So this could actually be like a marker of safety for aggressive early replacement, renal replacement therapy, early kind of diuretics, which is something that we're learning kind of as we're going through this, which is kind of
Thanks, everyone. I'm happy to take any questions at this point forward.
Brent, your mustache and beard looks great.
Um, thanks so much, Dr. Basmati. That was fantastic. I think, you know, right now, in terms of the audience here, we have a broad swath of specialties, and clearly this is applicable to everyone that practices acute care medicine. But for those who aren't savvy currently with ultrasound, or maybe are savvy with basic ultrasound, how would you describe sort of the learning curve for picking up these techniques, and sort of how you become competent and that sort of thing?
Rossi,
Yeah.
you want to take this one because you've done a lot of education on an international scope to bring sites on board for the Andromeda Vexus study.
Yeah. So it's tough. Like straight up, it's tough. It's not easy to learn point of care ultrasound. It's not easy to learn how to integrate it appropriately into practice and then have the time when you're busy clinicians. So I'm not going to pretend like this is an easy process. The approach that I would take if I was going to learn ultrasound from scratch right now, say I've always wanted to do it, but I haven't had the chance, it would be to start by finding some online resources. You can check out Western Sono, which is a website done by Dr. Arnfield here in London that has a lot of great videos, just to kind of prime yourself to what's out there in POCUS. Then I would take a course. If you're already in practice and you're not in kind of a training program, taking a course is a good way just to really immerse yourself. But the biggest pitfall is people take a course and then they don't implement it in practice. And that's just the starting point. Once you have those skills, you have to make it a deliberate part of your workflow. If you're a internist on the ward and you don't have an ultrasound machine on the ward, there's not really any chance that you will use POCUS in your practice. You're not going to go down to Emerge and then bring it up when you're in a busy clinical service. So then your options there are kind of advocating for your hospital to bring ultrasound machines onto your ward, or considering investing through your corporation or whatever in a handheld ultrasound device of some sort, which there's a lot of those. From there, I would then kind of want to seek out kind of ongoing mentorship and development. And there's tons of lectures talking about how to integrate POCUS into practice. And then I'd focus on that once the acquisition skills are down. From an actual Vexus perspective, there are courses. So in Montreal each year, there's a Vexus course that I'm an instructor at. So that's a great course. And there's increasingly more and more different Vexus workshops at various conferences to check out. Or if you guys want, we're happy just to come down to Toronto for night. John and I can go have some nice go to a nice restaurant, and then the next morning we can teach a Vexus workshop for anyone that's interested. So lots of opportunities there.
Just to add a research pitch, actually kind of participating under the auspices of a research study is actually a great way to kind of build your skills too, because part of that would be us training you, and then you'd be submitting your scans to us, and we'd be reviewing it for quality assurance. It's a great way to kind of build that training and teaching, and to get that experience with some supervision.
Yeah. I see a great question about IVC kind of in isolation to rule out congestive AKI. So the short answer is it has some value, but it's not perfect. So the reason why is you have patients that have venous congestion, but don't have a dilated IVC by traditional metrics. And that's the hard part. So traditional metrics of a dilated IVC are more than 2 centimeters and less than 50% collapse. But the problem with, and this is probably the reason why IVC fails in general whenever it's studied, is that there's a lot of factors that go into the collapsibility of an IVC. So the first is a respiratory effort. If you have somebody who's really working to breathe, that increased kind of pressure is transmitted to the IVC and makes it more collapsible. The second is that the IVC isn't actually a round structure. It's ellipsoid. And this is something we're doing as part of Andromeda Vexus. We're actually studying the IVC in short axis as well as long axis. And when you look at them in short axis, you very quickly realize why the IVC in long axis doesn't work. It is never circular unless it's severely congested. And so really it's this ellipsoid. The ellipsoid can sit kind of horizontally, it can sit vertically, it can sit on a diagonal. So when you're measuring it in long axis, looking at collapsibility, you might think that it's really dilated, but really you're just measuring kind of the ellipsoid in the longest axis. So what I would say is if you are worried about congestive AKI and you have a totally collapsed IVC that's slit-like, in the absence of any intra-abdominal hypertension, so belly's totally soft, you have an IVC that's totally collapsed. I don't think that patient has a congestive AKI, and I would be willing to bet money that they don't have a congestive AKI in 99% of the cases. When you start getting into the mid-range IVC, when you start adding confounding factors like pleural effusions, pericardial effusions, PEEP, intra-abdominal hypertension, all of those things, it becomes a little bit more gray. But and if you have a dilated IVC, that doesn't necessarily mean that you have congestion either. And so if one of the cool things is when you teach Vex's workshops, you always get the med student volunteers, and it's always like some like really fit 21-year-old guy that like runs a marathon every day. And if you think about it, if you run and you're like a kind of bigger person, you have like 10, 15, 20 liters of cardiac output going to your legs every minute. And that has to come up through the IVC. And one of the things we see is that these young people often have really dilated IVCs that are like 4 centimeters. And it's just that they're so used to having high amounts of venous return that you compensatorily get this like really, really big IVC. And so even that doesn't really work. Um, all that to say, venous congestion ultrasound is just one tool that we can add to the rest of it, but IVC has some value, probably not enough to base too many decisions on.
It just lacks the discrimination in the ranges where it commonly sits. In the extremes, it may be helpful, but in the range where we typically see patients, it lacks discrimination. And you know, a lot of one of the bigger factors like intra-abdominal hypertension and PEEP, those things change from day to day. And intra-abdominal hypertension is very prevalent in an ICU population. So those multiple confounders kind of have kind of pushed us and created a need to go directly to the organs and to say, what is the organ actually seeing on the venous side? And that's what Vexus, that's the role Vexus fills.
Yeah. So a question from Peter here, like how long does it take to do Vexus assessment? I would say that if I'm already at the bedside doing like a critical care echo or something like that, it takes me, and I've done a lot of them, but as sort of an expert, I would say 2 minutes to 3 minutes to rule out clinically important venous congestion at the bedside. From our study and for kind of newer people that are being onboarded, I think it's probably closer to 5 to 10. And there are some cases where the renal Doppler was really, really challenging to get, and that sometimes people struggle for 15 minutes on that. Once you get it integrated into your practice, it's really, really quickly just to look at the IVC and you're like, oh, that's kind of mid-range. Put a quick thing on the hepatic. You're like, oh, normal, portal normal, and you're like, I'm not even going to do the renal sort of thing. Yeah. And any last questions here? Oh, yeah, great question from um, Ari. What is the mechanism for pleural effusions contributing to congestion, or is it just a marker of congestion? Yeah, so one, it is a marker of left-sided congestion, yes, but it's not just that. So interestingly, when you have large pleural effusions, that pressure in your pleural space is actually transmitted onto your IVC in your right atrium and actually can cause downstream consequences of congestion. Same with pericardial effusions as well. And so there's some cool case reports out there of patients with severe venous congestion with like a large right pleural effusion. And when you put in a pigtail and drain it, the congestion's immediately relieved. And so is there like oliguria and their urine output picks up as well, which is just kind of like I would never think that a pleural effusion is causing my patient's AKI. Think it's associated, but maybe there actually is a bit more of a causal mechanism than what we traditionally think of, because all these things are really related. And one of the things that somebody pointed out to me that I was like, oh, like kind of obviously, but I was like, oh, that took me a long time to figure out was when we think about all the different body compartments, like the head, the neck, the chest, the belly, we're like, oh, like the chest is separate than the belly. I mean, they're actually the same compartment, just with a little diaphragm in between. You have like a little thin piece of muscle, and we call it a different category. So these compartments are obviously extremely related. We know that intra-abdominal hypertension affects our chest, which affects our brain and can contribute to elevated ICP. It's the same thing. If you have pleural pathology, that can contribute to intra-abdominal hypertension and intra-abdominal congestion too. It's a lot more related than what we think, but until recently, because we didn't really have tools to measure this, we couldn't really conceptualize it. But now that we actually have tools to measure this at the bedside, we can start seeing these interesting patterns and these interesting kind of multi-organ interplays in physiology.
Well, fantastic. It looks like there's no more questions on the chat. I just want to thank you both again for taking the time to come speak with us. This is really, really exciting stuff, and I think you know, such a great adjunct to our care. So pleasure and happy to continue discussions about your research program and how we can be involved in Scarborough.
We'd love to have you guys. Thank you.
Yeah, thanks again for having us.
Bye, everyone.
Yeah, take